Hello, I'm Dr. Jim Epstein, and this is Best of the Day from the 2013 meeting of ECHO, ESMO, and ESTRO, held this year in Amsterdam of the Netherlands. So we're going to be covering a number of important topics here at the ECHO, ESMO meeting. This evening we're going to begin with lung cancer, and joining me for this session is Dr. Ross Camage, who is the Director of Thoracic Oncology at the University of Colorado Cancer Center. Ross, thanks so much for coming.
Thanks for inviting me.
Well, it's been an interesting meeting so far. This is Sunday, so we still have Monday and Tuesday to go. It never seems like ESMO is quite as dramatic as ASCO, but there has been some new data and some very interesting information, especially in lung cancer this year, and I guess the other big area has been GI. But let's begin and talking about ALK-positive non-small cell lung cancer. Crizotinib has been on the market now for a year or so. People are getting used to submitting tissue for the ALK abnormality, and 1-2% of patients are eligible then for Crizotinib. But there are other agents coming down the pike. We've heard about the LDK agent that's under investigation, and then you presented some data at this meeting regarding the AP26113 agent. Tell us a little bit about that drug, how it differs from Crizotinib and some of the other agents in pipelines, and what these early studies have demonstrated.
Yeah, so Crizotinib is really the drug that put ALK-positive disease, and particularly ALK-positive lung cancer, on the map. Very dramatic responses that lasted for a long time, on average 8 to 10 months. But almost everybody is going to become resistant to that drug, and they become resistant in two main ways. So the first is about 50% of patients will actually become resistant, as it were, by progressing within the brain. And there's a certain amount of circumstantial evidence that the drug may have inadequate penetration into the brain, and that's why it's really a pharmacological failure. The other way of becoming resistant is progressing in the body, and that usually happens a little bit later in time, and there you've selected out, through Darwinian evolution, molecular changes in your cancer that make it resistant to the Crizotinib. We know some of those mechanisms by rebiopsy series. You can get mutations within the ALK kinase domain that alter the binding kinetics of the drug. You can increase the copy number of the rearranged ALK gene, so there's more of the target and relatively less of the drug.
So amplification.
Yep. And then you can get second drivers, and there's a range of different things that have been described. So there are several second-generation ALK inhibitors that are really a double whammy because they work on some of these mechanisms of acquired resistance, particularly those resistance mutations and copy number gain of the ALK gene. Mm-hmm. But there's also some evidence that they may, to a variable degree, also penetrate into the brain better and or be more potent with the amount that gets in. It's doing more work and getting responses in the brain mets.
So molecularly, are they dissimilar from Crizotinib?
They still have to fit into the same binding pocket, but they have a lower nanomolar IC50, so they're more potent, and they have a slightly different spectrum of activity in if you like, non-ALK related targets. So for example, Crizotinib is also a ROS1 and a MET inhibitor. Most of these other second generation inhibitors are not MET inhibitors. And one of the things that does is it removes one of the troublesome side effects of Crizotinib, which is peripheral edema, which is almost certainly an on-target effect of MET inhibition. Okay. So I presented Ariadne's AP26113. That's a potent ALK inhibitor. It's also a ROS1 inhibitor like Crizotinib. And we showed that in Crizotinib-resistant patients, it had a 61% response rate, which is essentially the same as Crizotinib in TKI-naive patients. We also showed one of those responders was actually a Crizotinib intolerant patient. So there's some people who just can't take Crizotinib. This was a guy who kept getting recurrent grade 3 transaminitis. And because the shape of the molecule is different, he didn't get that, but he still responded beautifully. And I think the most exciting thing is that we're starting to get not just anecdotal data of a brain met responding, but slightly harder data. So we presented that 8 out of 10 patients with active brain metastases, so brain metastases that were new or growing before you went into this drug, showed shrinkage, and the duration of that shrinkage was lasting up to 40 weeks and ongoing.
So does this drug also target EGFR?
So preclinically it does, but it targets the activating mutations of EGFR and T790M at something like 10 to 40-fold higher concentrations than it does ALK. So the real question is, great, you can do that in the lab, but can you get exposures high enough in a person for that to become a relevant target? And we presented data, and they've got 12 evaluable patients with known T790M, and the best response they've got is stable disease. So my statement would be, at the current doses they've tried, it is not yet an EGFR inhibitor.
Right, because I've heard that with afatinib, which is now approved, that in order to hit T790M, you have to increase the dose to the point that toxicity and adverse events become more of a problem.
So afatinib is an example of a second-generation EGFR inhibitor. And the interesting thing about them is that T790M becomes closer to the standard activating mutations in terms of the IC50, only about 10-fold higher, so sort of just almost that you could just reach it. But the trouble is that T790M is still way higher, the IC50 is way higher than it is for the wild-type form of the enzyme. So you can't get to T790M without skin and gut toxicity with an irreversible inhibitor. So whether to get to those levels, that level of toxicity will be tolerable at continuous dosing, we don't know. But so far, T790M activity of drugs like afatinib and dacomitinib has been pretty disappointing to date.
So in breast cancer, HER2-positive patients seem to have a higher tendency to develop CNS metastases. Is that also true in ALK-positive lung cancers?
So it is. No, we don't entirely know why. If you look at people at the time of diagnosis, they probably have the same 20-odd% rate of brain metastases. But if you look during their lifetime risk, it's really up about the 50% range. Now, is that because they have a higher tendency to go to the brain, or we're just keeping these people alive long enough to manifest that, which was the same argument they put with HER2 breast cancer, and we don't know. But what it does mean is if you're ALK positive, the brain is somewhere you've got to keep an eye on.
And I've heard some data that crizotinib does have some activity in the brain. What can you tell us about that?
So they presented here a poster led by Lucio Crino, and it was a retrospective look at some of the data coming out of the big single-arm study, 1005, and the randomized study against second-line chemotherapy, 1007. Now, you've got to understand that wasn't any intended endpoint of these studies. So they're really, going back into the boxes and trying to look at the data sets and figuring out if they can get something from it. It's kind of messy data. They claim, for example, a 7% response rate in brain metastases, whether they were previously treated or untreated, which is doesn't make any sense that way. And 7% is almost within the margin of error of repeating scans. Right. So that doesn't hold a lot of water. They present sort of non-progression data, but the trouble is many of these lesions were logged as non-target lesions when they did the measurements, and so they're just sort of present or absent. No one is really measuring these things. So I'm a little hesitant because certainly my clinical experience is this is a drug that I've never seen a response in the brain, and nearly 50% of my patients first progress in the brain. So I'm very suspect of that data, and what I'd really like them to do, especially from that randomized chemotherapy study, is show me the same data in the chemotherapy arm. They've only shown it from the crizotinib arm, so I can compare and do a retrospective review. Actually get central review of those MRI scans and give us the proper data, not just trying to fix it out from what was entered in the data set box.
Very good. You mentioned earlier that there are other drugs that are ALK targeted that are looking interesting besides the LDK378 drug. What other drugs are you having some interest in?
So the Chugai drug, which was developed in Japan and has now been taken over by Roche Genentech, is going to be shown tomorrow, and we've seen the abstract. In a first-line study, so in a TKI-naive population done in Japan, it had an amazing 93% response rate. Almost sounds too good to be true.
Right.
What we've seen in the abstract, now done in a Western population in the crizotinib-resistant setting, so similar to 26113, we have a much more realistic-sounding 53% response rate. LDK is a very similar situation. In that initial data that was presented maybe a year and a half ago, in the crizotinib resistant initially claimed an 80% response rate. Then as their data set expanded and it became more mature, it came down to a 57% response rate. So things that are too good to be true usually are too good to be true.
Right. What do we know about the duration of responses with these newer agents like the Ariad drug and the Chukai drug compared to the duration of crizotinib responses? Are they pretty similar, or are the newer drugs providing longer duration?
So that is a brilliant question. One of the issues is we're being presented with very early data where we can feel fairly reliable about the response rate, but we don't have maturity of PFS data or duration of response data. So we don't really know the answer to that question.
So what are you doing with your crizotinib patients who progress? Not particularly in the brain. I'm sure some of those patients are probably eligible for gamma knife treatment and rarely resection. But what are you doing? Are you putting those people on clinical trials with drugs like the AP26113?
Well, let me pick up on your last point. So because sometimes when you see these people, their first site of progression might just be a simple deposit, one simple deposit in the brain, or occasionally one simple deposit in the body. So that first resistant clone, you've caught it before it's popped up anywhere else. We've already published data that if you treat that area, for example, with focused radiotherapy, stereotactic body radiation therapy, and keep the crizotinib going, in the brain, it takes on average 7 months before you get anything else showing up, and in the body, maybe about 4 to 5 months. So you can really extend out the benefit of these drugs by close surveillance and what we call weeding the garden. So when these things pop up, you don't panic, you don't throw the garden away, you just pull the weed out and keep the drug going.
So similar to what you do with oligometastatic disease with an EGFR mutant.
Yeah, so we call it oligoprogressive disease. So clearly you get to the point when either there's too many things popping up or it's not in an area you feel you can irradiate. Then I'm usually putting people on one of these second generation inhibitors on a study. You've always got chemotherapy to fall back to. Right. We tend, if we use chemotherapy, to try and use a pemetrexed-based regime. There is
most of them are adenos.
Well, it's more than that. There's some evidence that ALK positivity, a significant proportion of ALK positivity, maybe as much as 60%, may be super sensitive to pemetrexed. Okay. It's not quite as reliable as the crizotinib, but if you look at the waterfall plots in that crizotinib versus second-line chemotherapy, there was a big difference between how the pemetrexed group did and the docetaxel group. You can have either or, but they were, even though in an unselected population they're perceived as equivalent, they're clearly not equivalent in ALK-positive lung cancer.
So if you have a patient who is on crizotinib, doing well, but develops oligoprogressive disease, not necessarily in the brain, but in a few different spots, do you add pemetrexed or do you switch them?
Well, if it's oligoprogressive, I'll give them radiotherapy and keep the drug going. If it's more widespread progression, usually I try and put them onto the clinical study. Okay. But you know, if I was doing a consult on somebody in the middle of Alaska and there's no way they could get on that, then I'd suggest adding in the chemotherapy but keeping the crizotinib going.
Very good. All right. Well, there was an interesting session that I was able to get to this afternoon in which you were one of the discussants. And one of the papers had to do with KRAS mutations and the Tailor Trial. And then the other one was a novel agent, this AstraZeneca drug, 9291. So let's briefly cover the Tailor Trial data. Tell us a little bit about that trial and their efforts to look at the importance of the KRAS as a biomarker.
The Tailor study is I think, a wonderful study because it was really an investigator-initiated study, wasn't driven by pharma. There's all sorts of flaws associated with it. They changed the primary endpoint. It didn't meet its primary endpoint. It's made its secondary endpoint. But it really addressed a very interesting question. We had known for some time that EGFR mutants were the dominant drivers of benefit from EGFR TKI. So they asked a simple question. We had previously seen studies like INTEREST and TITAN, which had shown that an EGFR TKI in an otherwise unselected population was equivalent to docetaxel, you know, to solidifying the idea that this was a valid second or third line treatment option. What they did in the Tailor study was they said, we're going to pre-screen people. We're going to take out the EGFR mutants. So we have an EGFR wild type population, so not unselected, but EGFR wild type. Now, which is better, erlotinib or docetaxel? And their study, which was published in the Lancet Oncology earlier this year, clearly showed that for progression-free survival, docetaxel was the better drug. Neither drug was great, I have to be honest, but there was a statistically significant improvement in PFS. That was a secondary endpoint. They actually didn't meet their primary endpoint, which was an overall survival difference, but the trend was also in favor of the docetaxel.
So they selected out the EGFR mutant patients, but they didn't select out people with other mutations.
No, but they did capture that information. So what we saw today was they said, let's look at the effect of KRAS mutation within that population we had, and whether the KRAS mutant patients did different from the KRAS wild type population. And what they showed, so let me back up. So there had been, early in the development of EGFR tyrosine kinase inhibitors, one of the strongest initial biomarkers was being KRAS wild type. So when they did the retrospective subgroup analysis of BR21, that landmark study that was Alatinib versus placebo in the second and third line setting, strangely enough, being EGFR wild type, your overall survival advantage wasn't preserved. Being EGFR mutant, amazingly, your overall survival wasn't preserved, but they only had 37 patients they were analyzing. But if you were KRAS wild type, the overall survival advantage was preserved. So people started to say, was there something special about KRAS wild type? So that led into, let's look within the Tailor study, where does KRAS wild type matter? And what they showed was that, yes, there was a statistically significant difference in progression-free survival if you were KRAS wild type, but in favor of docetaxel. Exactly the opposite from what the earlier data might suggest. And the explanation is really simple. Probably because KRAS mutations and EGFR mutations are almost totally mutually exclusive. You know, they're yin and yang.
Right.
If you take a KRAS wild type population, you capture every EGFR mutant there is, because they're all contained in the other side of the coin. So that's why you initially, that was a way of enriching for EGFR mutants and removing some from the denominator because you took out all of the KRAS mutants. Why didn't it work in the Tailor study? They'd already taken out the EGFR mutants. Yeah. So really they were comparing KRAS mutant with a KRAS wild type and EGFR wild type population. And the fact that it didn't work solidifies the idea that the initial advantage of being KRAS wild type was it was just a way of selecting for EGFR mutants.
Very interesting. Well, tell us about this new agent, which also targets EGFR, the AZD9291. How does this differ from Erlotinib and some of the other anti-EGFR TKIs that are in the pipelines?
So 9291 is what we call a third generation EGFR inhibitor. And there's only one other that we've heard about, which is Clovis's 1686. So a first generation inhibitor is Alatinib and Gefitinib, and they're reversible inhibitors. They have a lower IC50 for the activating mutations than the wild type form, and T790M, that resistance mutation in the EGFR, is way out of their reach. The second generation inhibitors, the so-called irreversible inhibitors like Afatinib and Dacomitinib, have a low IC50 for the activating mutation, an IC50 for the wild type form, which is relatively close to that, and T790M just a nudge above that. So you can't get to T790M without having wild type toxicity.
Without hitting the wild type also.
Whereas in the reversible ones, because the order is T790 is way up here, wild type's here, and there's a 25-fold margin between the wild type and the activating, you and I know you can have a patient that you dose reduce on Alatinib. If they have an EGFR mutation, you can get to the point where they have no skin or gut toxicity, but their cancer's still under perfect control. Okay, the third generation inhibitors, they flip the order. So what happens is they have great activity against the activating mutations, almost equivalent activity against T790M, and maybe a 40-fold window before they hit the wild type form.
So how is their activity against the standard EGFR mutant? The exon 19s and the others, is that equivalent to Erlotinib and Afatinib?
So preclinically, yes. Clinically, we haven't seen that data because the way they're chasing down a development path is to go in the T790M population. That's the fastest path to approval. So we saw for 9291 that they're in the dose escalation phase. They're still working their way through, but they're stacking it with patients that they know have T790M. And they were seeing responses even at the lowest dose. If you look across all of the doses, they have something like a 46% response rate. If you look in those who are known to be T790M positive, it was something like a 56% response rate. So this is a game changer. This is really bringing T790M, which is a mechanism of acquired resistance in 50 to 60% of EGFR mutant patients, suddenly saying there's going to be a targeted therapy for these people within a short number of years.
So is this agent, I'm sure the first target they will go for is the T790M, but are they going to be looking at using it first line?
Well, that's the sensible thing to try and do, because you have something that may be better tolerated because it's got a bigger window. Obviously, it depends on how you dose it. It's interesting that as they went up on the dose, they started to get some grade 1 skin and gut toxicity. So they may have a drug that is, so good even at their lowest doses, they don't need to push it up any higher. But if they choose the dose right, they may have minimal skin and gut toxicity, great control of the standard mutation, and they suppress the mechanism resistance from occurring. So in theory, they might be able to extend out that duration of benefit more than the sort of 10 to 12 months we expect with a reversible TKI. Now, AstraZeneca hasn't announced any plans to do that. Clovis has. So Clovis was the drug that was presented at ASCO that looks relatively similar. I thought as I was wandering over here, I wonder if that's because AstraZeneca also owns Gefitinib, so they would be competing against themselves. But if you and I were designing it, we would try and do a first-line head-to-head study.
Absolutely. And Gefitinib still not available in the U.S. and not likely to be.
Yeah.
So we'll wait and see. Well, let's move on and talk a little bit about the checkpoint inhibitors. There was such a tremendous amount of excitement at ASCO about the anti-PD-1 agent a year and a half ago, and then the anti-PD-L1 agent from Genentech. And there are a number of these agents that are in the pipelines. Merck has a couple, and a number of other agents have one. But there was a presentation at the ESMO meeting this year regarding the Genentech drug MPDL3280A, I think they call it.
I don't remember the phone number of the
Yeah, but it's an anti-PD-L1. And what is the advantage of targeting PD-L1 versus PD-1? Are they going to potentially combine these two for a double sort of blockade? Or where do things stand right now, and what new evidence have we learned at this year's meeting?
So there are two main camps for these immune checkpoint inhibitors. So one perception is that the more that you block the receptors, the more you're going to block the masking of the immune system and bring in the immune system to reject the tumor. The other is you want to be more selective about which ones you block, because some of those things will also increase your risk of autoimmunity. So if you're in the PD-1 camp, you say, we're going to have the most effective drug. If you're in the PD-L1 camp, you say, we're going to have the safest drug, and very similar efficacy. We saw the PD-L1 from Genentech presented today. It has about a 23% response rate in an unselected population. They make a big point of saying no grade 3 to 4 pneumonitis, which is what they'd seen in about 5% with the PD-1 inhibitors. But you've also got to remember the numbers are pretty small.
Still small.
When you're talking about something that might be running at 5%, it just might be dumb luck that you haven't had a case yet. So we got to let that mature. The really interesting thing, particularly as these things, they're not a free lunch. You can get autoimmune conditions. Is there any way you can pre-select people to say your chance of benefit is going to be greater, so your risk-benefit ratio is going to be more attractive?
So enriching the population.
Yeah, and we saw two things. So one is what we'd heard with the other drugs before, which is that immunohistochemistry for the ligand, PD-L1, certainly enriches for those who respond to the drug. And at its most extreme, if you were 3+ on the IHC, so the highest score, you had something like an 80% chance of a response rate. And there's a gradient. But the trouble is the marker is not perfect, because if you didn't express it, you still had something like a 10% response rate. The other thing that was presented at this meeting, which I hadn't seen before, was the association between smoking and chance of response. So there's a theory. So what the immune system is reacting to is neoantigens, just messy proteins created from mutations. So if you have a smoker's cancer and you've got a more genetically complex cancer with more messy genes, you probably have more neoantigens, and so you're more immunogenic. And they showed, for the first time I've seen, that the response rate was certainly higher in smokers than never smokers.
So a lot of the novel agents that we've seen, the EGFR targeted agents, the ROS1, the Al-Khatib, these are mostly non-smokers that seem to develop these molecular abnormalities. So this agent might be better for those who are the smokers. And what about in squamous cell? Most of these people are smokers.
So there was an early signal with many of these drugs that squamous might have a higher response rate than adeno. Again, as the data has matured, that difference has tended to even out. I mean, the real question to ask is to say, is smoking an independent variable, or is it a surrogate for saying you're going to express more or less of this marker you can detect by the immunohistochemistry? And we haven't seen that yet. But for example, what you're really trying to find is, can you identify a signature that says you have a 0% chance of responding, and therefore you don't expose people unnecessarily to the risks? So maybe if you were a never smoker and were IHC 0, maybe they'd have a very low response rate. Right. But we don't know that data yet.
Very good. Well, this has been great. Anything else that has struck you as new or exciting at this year's meeting?
No, I mean, I think that the big news was the AstraZeneca. I think that was, and maybe because it's a European country, that's why they presented it here for the first time.
That's great. Well, Russ, thank you so much. We really appreciate your coming and sharing your perspective on the data. It's always nice to sit down with somebody who's in the trenches and knows all the latest data and how to apply it to one's practice.
It's my pleasure.
Very good. And thanks to all of you for watching this segment of Best of the Day from the 2013 Echo, ESMO, and Estro meeting in Amsterdam, the Netherlands. And I hope you will look for more Best of the Day programs from this year's meeting. Thanks again.